This is just as an example, if we could imagine catching all lesions at the earliest stage, we have the best chance to really change outcomes. And that's what really has excited me and kept me passionate about STRATICYTE for, well, about the past 7 years since I've been involved. This is a patient of mine, 34 years old, with no risk factors, but who had a pre-existing leukoplakia of the lateral tongue, which was biopsied. And because the diagnosis was moderate dysplasia, that patient was lost to follow-up. Really felt from the oral maxillofacial surgeon, their relationship did not include additional follow-up. And so that patient ultimately returned after a period of about 2 years, having developed cancer. But even in that setting, we want to catch these early. We want to see patients who have oral cancer at the early stages. Then we can easily do a neck dissection. This patient had such a small lesion, I could close it primarily. And all across the board, outcomes are better. We have lower costs, we have better survival, and less morbidity in treatment. So what are the opportunities as we see these white and red lesions in our office, in our practice? Well, the first and probably the most important is we need to know the risk of progression to cancer. In fact, that's all we care about. We don't wear seatbelts. We wear seatbelts in case we get in an accident because we accept that as a realistic possibility when we get in a car. We have to have the same mindset when it comes to oral precancer, that we really care if it becomes cancer, and we need to know whether or not that's going to occur to be able to treat these patients. So we'll see sometimes in the literature from very well-known authors that there's still a consensus that the biological behavior is unknown, and we really don't know quite how they'll behave.
So I'm just going to give you an example of a patient that I share with a head and neck surgeon here in town. This is a patient who came in, he's immunosuppressed. We have these kind of patchy white lesions, which for the general dental folks, we'll say maybe you could consider lichen planus. I think most of us looking at this are saying, well, it doesn't really quite look like lichen planus, but it is multifocal. And he has areas on the palate and the buccal mucosa, the gingiva, and remarkably involved on the tongue here. And so this is a patient who has proliferative verrucous leukoplakia. The thing here is that some of these sites that are biopsied, when I look at the histology, if we look back a few decades and you look at the criteria that we use to grade histology, or even in this era, what many general pathologists, myself, other colleagues may actually do is we're not seeing obvious cytologic atypia in some of these cases, but we're seeing architectural changes that are concerning. So you'll get back a diagnosis, which I have a tendency to do less nowadays, of like an atypical verrucous lesion or atypical papillary proliferation with dysplasia or without dysplasia. Some of these cases really cytologically look very bland, but are architecturally remarkably proliferative and abnormal. So this is the crux of the problem, is that this is what we're looking at as a pathologist, but does that really correlate to the transformation rates of this lesional process, right?